Antidepressants are among the most commonly used medications in the UK and US, with the number of prescriptions and duration of use rising every year. Looking at official figures for the UK from 2017, consumption had increased by 170% since 2000, with over 7 million adults prescribed an antidepressant in England alone, which is 16% of England's adult population. And the number of individual annual prescriptions now exceeds 65 million. Previous research on long-term use has estimated that a third of people in the UK who take antidepressants for more than 2 years have no evidence-based clinical indications for continuing to take them. The same was found for other non-UK settings, and this means then that approximately 1.2 million long-term antidepressant users in England and 6 million users in the USA could be taking antidepressants without clinical indication and could therefore try to withdraw. Here to talk with us tonight about their perspectives on the use of and withdrawal from SSRIs are Professor David Healy and Dr. Ali Ajaz. Professor Healy is Professor of Psychiatry. He's also a scientist and psychopharmacologist and has authored more than 220 peer-reviewed articles and 25 books, including Pharmageddon and his most recent book, Shipwreck of the Singular Healthcare's Castaways. Dr. Ajaz is a psychiatrist who's qualified in the specialist area of forensic psychiatry. He authored a number of publications in peer-reviewed medical journals and takes a functional health approach to improving brain health. He has his own brain health clinic in London and actively continues teaching medical students and conducting research. Professor Healy and Dr. Ajaz, thank you both very much for joining our show tonight. As mentioned in my introduction, there's been a worrying increase in the number of antidepressants prescribed. Why do you think this is? Is life more stressful? Are we less able to overcome difficult emotional states? Or are doctors just a little too prescription trigger happy? And can antidepressants actually cure depression and anxiety? Maybe Professor Healy, maybe you want to start?
Yes, sure. Okay. And I think the reason we get more of these pills now is because they're being marketed at us. It's nothing to do with an increased rate of people having nervous problems. Part of the problem after you go on the pills is they do change you. And part of the change means that it can be extremely difficult to get off these pills. So part of what we got at the moment is it's not just a vast amount more people are being put on these drugs each year. It's more a case of at the end of each year, there's a large number of people who can't get off them, and that's increasing the whole time. So there's a small increase of people being put on them fresh each year, but the biggest problem comes from those who have been on them for a while and aren't now able to get off them. And one of the most striking groups is pregnant women are increasingly using antidepressants during their pregnancy. Part of this is because they can't get off them and they're told by their doctors, well, it's more important for you to be happy than to worry about anything else. This isn't the case. These drugs are not safe to take during pregnancy. But as I say, it can be so hard to get off them that even when you're highly motivated, such as to keep your baby safe, you find it difficult to do so. But the reason why a lot of women go on them before they get pregnant and maybe even thinking about getting pregnant is, unlike food and everything else like alcohol and kind of smoking and all, these drugs come with a tag on them which says they work. And that puts a bit of a moral onus on us. Why are you not taking these pills that work? So
Is that your perspective as well, Dr. Ajaz?
Yeah, I agree entirely with that, but just coming at it
Mm.
from a slightly different perspective, I think it's to do with our healthcare system as well. So most of the prescriptions for antidepressants are done by primary care physicians rather than psychiatrists. primary care physicians out there, and they're on the front line. Most of mental health is in the community rather than in specialists. So we have GPs that have 7 minutes with a patient, and you can't really get anywhere with 7 minutes doing a psychiatric assessment. So it becomes useful in the sense of, it's a pragmatic, practical approach, and perhaps it's not in the kind of but effectively, I think that's what it is. Antidepressants are given not only for depression, but for anxiety, for insomnia, for OCD, for panic attacks, for PTSD, for pretty much most mental health conditions. And I think it's a tool that's used by doctors to give patients something when they can't really do the problem justice. And I think that's a bit increasing problem in primary care services. GPs are disenfranchised. It's such a hostile environment to work in, and even if you're someone who wants to go against the flow, I think over time you end up relenting to survive. And most of my colleagues from medical school are GPs, so I know a lot of GPs, and this is pretty much the overwhelming sentiment. So there is an issue with the way the healthcare system is set up as well, that is really bringing antidepressants to the fore.
Okay, that makes sense. So what are SSRIs exactly, for people who don't know? What's the difference between SSRIs and the old style medication?
Quickly, the first antidepressants we had came on the market in the late 1950s, and they were better drugs in the sense they got people who were more severely depressed well. But they did a range of different things. And one of the things that happened in the early 1970s was a man called Arvid Carlsson, listening to what doctors and patients said the older drugs did, said, well, it's interesting. Among these older drugs, there's a range of actions they have, and the people who say that the drugs make them less anxious, make them more serene, are on drugs that also inhibit serotonin reuptake. So let's make a pure serotonin reuptake inhibitor and see what these do. And these are the drugs that we call the SSRIs. The term SSRI is not a scientific term. It's a marketing term coined in the marketing departments of SmithKline Beecham. Okay. Now, it turned out that when we made these drugs, they're less effective than the older drugs. And this actually suits the companies quite well. They didn't want the best antidepressant in the world. They wanted to be able to give these drugs to people who were previously on benzodiazepines. They wanted a big market as opposed to powerful drugs that would treat a serious illness. The money is in the nervous problems people out in the community have, rather than the people who are ill in hospital. So what they wanted to do was to convert cases of Valium into cases of Prozac. So essentially, from a company point of view, the SSRI group of antidepressants are a little bit the same thing as the benzodiazepine tranquilizers once were.
Okay. You've both given expert testimony in civil trials. Professor Healy, for example, you've been involved in a murder case. I read about that recently, where a 60-year-old man killed several members of his family 2 days after starting on an SSRI. How does that happen? How do SSRIs cause people to become suicidal or homicidal even? What's going on here?
One of the interesting things about this group of drugs that I hope to bring out in a talk later on in the course of this is other drugs give us problems, the person who's on the drug. What SSRIs do is they can give other problems as well, as when you become homicidal, the person who isn't on the drug ends up dead. So in terms of becoming homicidal or becoming suicidal on these drugs, what happens is they can do a few different things. They can make you agitated. When I say agitated, I mean severely agitated. You really feel agitated to the point you prefer to be dead. The other thing they can do is they can make you psychotic. You can start hearing voices that say, kill yourself. And finally, they can make you disinhibited. They can make you emotionally blunted so that thoughts lots of us may have when we're under stress, like I wish I were dead, but you don't
Mm.
act on it because you're too anxious to do so. If you're on these drugs, you can be emotionally numb to the consequences of an action like
Mm.
killing yourself. So
Mm.
there's a range of things they can do that can cause problems like this.
Mm. And do we know what actually happens in the brain? I mean, is it chemical reaction, some sort of change of, chemical reactions, or what is going on? I mean, how do these
Well, I think you're
effects
making a
happen?
mistake. I
Yeah.
think you're making a mistake here. The
Mm.
last thing I'm interested to do is to work out what's going on in the
Yeah.
brain with these
Mm-hmm.
drugs. The key
Mm-hmm.
thing I'm interested in is when people tell us about what's happening to them on these
Mm.
drugs, we don't believe them. The key thing
Right.
is not how it happens, but what's happening. And when they say to us that they've
Mm.
become suicidal, why are they not believed? When they tell us that they aren't able to make love anymore, why are they
Mm.
not believed? These are the key things. In the case of thalidomide and the fact that it causes birth defects, to this day, we still don't know how it's caused,
Right.
but
Yeah.
you have to believe that it can cause it because you see the
Mm-hmm.
child right in front of you. The problem is when we talk to doctors about things that are not right in front of them, they tend not to believe the evidence from us in favor of the evidence in articles that they've read, which are often ghostwritten articles with no one been able to see what the data behind the clinical trial that this article is
Mm.
reporting on actually showed.
Mm-hmm. Dr. Ajaz, do you want to add anything to?
Yes, plenty to add. Hopefully you can hear me a
Yes.
bit better now.
Yes. Yes, we can hear
Okay,
you.
great. Excellent. Yes, I mean, just on in terms of the behavior side of things, it's a really important point Professor Healy mentioned about the feeling numb. I get that so much from many of my patients that come to me and say, well, I just want to get off them because I'm feeling just not myself. Now, I don't feel down, but I don't feel anything at all. And so when you're doing the research and you get people to kind of fill out these forms about how down they feel, the fact that they're not feeling anything is seen as a positive outcome. That actually you're overcoming your depression because you're not feeling down. And
Mm.
there's so many holes in the research that goes around this, but it's a really important point, because that can lead to people being disinhibited. I think it's a kind of a psychological process that happens. And there was a study from this year, in fact, from the University of Cambridge and Copenhagen, and they looked at just this sense of emotional numbing, and they play that out with reward behavior. And what they found is that people on SSRI antidepressants for just 7 days behaved really differently. So when we learn how to behave, we're either reinforced by something positive, or we have a negative aversive reaction that we stay away from. But when you're on antidepressants, your brain doesn't work in that way. You don't get reinforcement from positive things and stay away and caution from negative outcomes. So it really changes the way that you think and the way your psychology is, and then you can end up anywhere, pretty much anywhere. And that was quite worrying that from 7 days of taking
Mm.
SSRIs that you could have such an effect. And that's really
Mm.
important. And it's a common reason why people come to me and say, look, I just want to be off these now. But they always kind of precede that with, I'm not sure whether they're doing anything.
Mm. Mm-hmm.
I think there's very few patients I've come across that say, look, doc, I took that drug and it really helped me. And there are some people that report that. Doesn't necessarily mean that the drug is doing what it's designed to do. But I get that, but it's far less than people saying, I don't know whether this works and I don't know what it's doing, and I'm getting some
Mm.
side effects and I just want to come off it because I don't want to be on drugs forever. And plus my own doctor is more than happy for me to be on this forever.
Mm.
And so
Mm-hmm.
yeah, so that's a really important point. That really, this kind of sense of kind of feeling numb and what that can
Yeah.
lead to.
Yeah.
Yeah.
Mm-hmm.
In terms of other kind of the theme of numb, yeah, there's kind of sexual side effects is something which is really underreported, and I think mainly because it's really difficult theme to talk about. But numbness in terms of your sexual function, in terms of your reward that you get from that, is something which, quite worryingly, can be quite a permanent issue. So this post-SSRI sexual dysfunction, which is more and more in the public conscious. It's not something I was very familiar with until a few years back, but these irreversible effects in terms of sexual function and kind of sex and everything that goes around that for men and women is really worrying and really alarming. We just don't know how big of a problem that is, but there's no doubt that it is a problem. So I think there's a lot more to be worried about than what we're already worried about.
Yes, that might be a good time for you, Professor Healy, to start your slides and talk, because you're going to talk
All right.
about this
PSSD.
particular
Yes,
PSSD,
okay,
because that
right.
is exactly what Dr. Ajaz is talking about
Yeah,
there.
we did rehearse that.
Just
I don't
mentioned.
think.
Yep. Right. Can you see the slide? Okay. So let me talk to you about post-SSRI sexual dysfunction. And the slides are not moving forward at this end at the moment. Right. There we go. Right. And now, can I minimize the box over here on the right? There we go. Right. Okay. So one of the two people you see here is not able to make love because they're on an antidepressant. We don't know which of the two. When you actually have a problem on an SSRI antidepressant, it's one of those problems that you aren't the only person that has it. The person you sleep with, the person who's your partner, may also have a problem because they aren't able to make love if you aren't able to make love. It's a bit like SSRIs and homicide, where a person who isn't on the pill may end up dead as a result of the pill. Now, I said one of these people isn't able to make love because they're on an antidepressant, but it could also be isn't able to make love because they were on an antidepressant. Within 30 minutes of the first SSRI pill you take, your genitals become numb, orgasms become mute, and over time while you're on the pills, your interest, your desire to make love drops off. This is the kind of thing that if you're told anything or if you read about it, you'll hear that, well, yes, this will all clear up when you halt the pills, but we've known for 40 years or more that actually, no, this doesn't always happen, that there are people, when they halt the pills, the problem becomes much, much worse. They become even more gently numb and emotionally numb as well. Their orgasms disappear completely, and their interest in making love drops off totally. This is a problem called post-SSRI sexual dysfunction, PSSD. It happens to women and men, it happens to old people and young people, cis and trans, every ethnic group on earth. We don't know how or why it happens, and we don't have any cures. It may recover after a few years, or it may last forever. Now, given that we've known about this for so long, the question is, when we're put on one of these drugs, why is no one told that this can happen? Why, when we take the problem to our doctor to talk about it, do we often get laughed at? And I mean it, we often get laughed at, and people even get locked up for their crazy ideas. When we bring the problem to the doctor, why aren't they listening to us and looking at us and agreeing, yes, it seems obvious that this pill has caused the problem? Who are they listening to? Who are they looking at? Are they not able to recognize when a drug causes a problem anymore? Is it not part of their training? Or do they need to seek permission from someone in order to agree with us that the drug has caused the problem? And if so, who do they need to seek permission from? This problem about antidepressants and sex goes back to the late 1950s, early 1960s, when some of the older drugs we had, like amitriptyline, which were as a group, much more powerful than the SSRIs, came out. They treated a condition called melancholia, which is severe depressive disorder, unlike the SSRIs, which only treat mild depressive problems. But even though melancholia, which in its own right causes a loss of libido, doctors were able to distinguish the problems being caused by their pills back then from the problems being caused by the illness. But on an SSRI, where you have no loss of libido from the conditions they're given for, doctors these days will say to you, well, actually, it's your illness that's causing the problem, not the pills. We knew in the early 1970s, when we gave some of these older drugs, that in a tenth of the dose used to treat people who were depressed, they could make genitals numb to the point where it could be used usefully to treat men who had a premature ejaculation problem. We knew in the early 1980s that some people, when they halted these drugs, went on to have an enduring sexual dysfunction that could last for ages. In the mid-1980s, when companies were doing healthy volunteer trials of the SSRIs that later came on the market, what they found was many of the healthy volunteers, young, healthy men who had no problems at all, complained bitterly about the sexual problems they had on these drugs. And in some cases, it looks like the problems went on after the 2 or 3 week period been on these drugs came to an end. But doctors like me running clinical trials for the pharmaceutical companies in people who are depressed and anxious weren't told about this. What we were told was, don't ask about sex. And when we didn't ask about sex, it meant that the companies ended up being able to claim that their clinical trials showed that less than 5% of people had any problems making love while they were on their drug. And the hint was that once you halt the drugs, if you're going away for the weekend or whatever, everything will be just fine. By the early 1990s, when the SSRIs were on the market, companies had begun to get a flood of reports to them about people who had enduring sexual dysfunction after they halted the treatment. But we weren't told about this. Part of the reason we didn't get to hear about it, perhaps, was that people who have PSSD are the same kind of problems caused on other drugs, aren't inclined to let anyone else know that this is what they have. It's the kind of thing you want to keep to yourself. So for more than 30 years, people kept quiet about it. They didn't link their name to it. They didn't say, I have PSSD. But in the last few years, groups like PSSD Network have changed all that. They've said, look, we've got to come out and tell people we have this problem and ask them, why are you not doing research on how it happens and how to put it right? And actions like this have made a big difference. It's getting harder and harder for the media, the politicians, and others to ignore problems like this. And I want to recommend something the PSSD network have been doing. They produced a series of podcasts recently, and here's one of the podcasts which features 3 ordinary guys analyzing what's gone wrong with them, but at the same time telling us something extraordinary about what's gone wrong in healthcare generally. They've put their finger on what's going wrong for all of us in a way that very few other people have done. And here's some quotes from the podcast. It's a podcast that I recommend you all tune into. One of the 3, as you saw, was called Bryn, and he's saying, getting PSSD undermines your faith in the medical establishment and the whole system of science as we have it. The fact that none of these professionals understand this condition or know anything about it when we know we have it. It's not some vague feeling. Losing your libido is equivalent to going blind or deaf. It's that level of sensory impairment. And Roy chips in and says, it isn't just genital numbness, you become emotionally numb as well. So he says the same can be said for losing your emotions. I felt I lost not just one, but 2 senses, my sexuality and my emotions. And Brennan comes back and says, look, if we want to be believed, we have to remember just how incredible our story sounds. It's a hard thing to wrap your head around. My dad says it's not possible a drug could cause these effects. It wouldn't be on the market if it did. Now, let me pick up that last point. Well, no, actually, I'm going to pick it up after the next slide. If you've got PSSD or any problem on any drug these days, increasingly you're up against, well, you're going to have a Tiananmen Square moment, and your doctor, if your doctor agrees with you about that you're right about what's wrong, you're both going to have a moment like this, which is you're up against a ghost-written medical literature. The literature reporting on the clinical trials of these drugs is ghost-written. It's not written by the people whose names are on the authorship line, and it's increasingly fraudulent. You're up against regulators who don't have the clinical trial data, who may have been told by the pharmaceutical company, look, in this trial, our drug didn't work and wasn't safe, even though there's an article out there in some of the very best journals saying that in this trial, the drug worked wonderfully well and was safe. The regulators don't say anything about this, even though they know that the literature is essentially fraudulent. Up to half of the trials of antidepressants were negative trials, and many of them are published as positive. Even if the regulator did come out and talk about the problem, one of the issues regulators have is they don't know how to analyze when a drug's causing a problem or not. They're not doctors, they're bureaucrats. So let me take you to this. This is NHS Digital. Let's say you're prescribed an SSRI by your doctor, and you might go in the UK, if you're in the UK, you might go to NHS Digital. We're taking the same approach that MHRA take, and EMA in Europe, and FDA in the United States. NHS Digital will tell you about some of the common effects these drugs have. They can cause nausea, headaches, you may feel a bit nervous, etc., etc. When you ask them why they picked out these side effects to let you know about, they say, well, we picked out the ones that are most common. But the most common side effects are the sexual side effects, which happen in close to 100% of people that go on these drugs. So if you ask them, why do you not include the sexual side effects? The answer, and I have it in print, is we don't want to deter people from taking their drugs. Now, this essentially means that NHS Digital and MHRA and EMA and FDA are all in the business of getting you and me to live the life that companies want us to live, rather than trying to engineer the situation so that these drugs, if we choose to use them, are going to help us to live the life that we want to live. Further on, deeper into this, if you can find that NHS Digital do mention that, if you're a man and you go on these drugs, they may possibly reduce sperm quality. Well, the facts of the matter are, if you go on these drugs, your sperm count will plummet. There's almost nothing else that will reduce your sperm count in the way as much as SSRIs will do. If you're a woman, you're not really told anything in particular here. What they certainly don't tell you is that these drugs double the rate of miscarriages, double the rate of terminations of pregnancy, possibly because they disinhibit you, and double the rate of birth defects. You're not told this. So where does that leave us? Well, 4.5 years ago, the BMJ produced this feature article, which said that in Britain, we're not making love the way we used to do. And this is going to be the same for the United States and Canada and all of the Western world. It's not just the UK, where 15% or more of us are on these drugs, which of course means if you take into account that it's not just the person on the drug that's having a problem, it's the person that they live with, it will also be having a problem. It may mean that 20 or 30% of us are not making love. The BMJ article tells you it's depression that's causing the problem. It's not depression that's causing the problem. Most people getting put on these drugs have no problem making love before they go on the drugs. But the BMJ article doesn't mention that because BMJ's lawyers would not let the article be published if it did mention it. So, a month or two ago in the UK, these figures came out which said that the fertility rate in the UK is 1.56 births per woman. The replacement rate is 2.0, and when the replacement rate in European and other countries fell below 2.0 first, there was panic. We're not replacing ourselves. What's going on here? Now, part of the problem is an aging population. The more people who are old there, the more likely the figures are to fall. But I think it's unquestionable, with 30% of people in the UK not able to make love the way they would wish to, that the drugs are also playing a part here. The Canadian rate is even lower than this. But I want to make one or two more points quickly before I end. One is, I'm Irish, I'm an immigrant to the UK, and like millions of Irish people, my view is that we have made the UK a much better place than it would have been without us. So I am pro-immigration. And I want to let you know that of this 1.56 births per woman in the UK, 30% of the births in 2020 in the UK were to women born outside the UK. And 66% of the births in London were to a parent who was born outside the UK. So if you stripped those births out, and one of the points to make is that immigrant populations are much less likely to be taking SSRIs than the native population are. So if you take those births out of the frame, the reproduction rate in the native population is probably closer to 1.0, which is catastrophic, or would be catastrophic, except we're being helped by immigrants coming into the country, but also every country in the Western world is probably affected similarly. The UK is not going to stand out because everywhere in the Western world is facing much the same problem. Now, the problem, medicines are chemicals combined with information. Chemicals are tricky. It's important that we do research on it, and research that I'm involved in show that the way these chemicals are causing this problem may ultimately lead us, if we can work out what's going on, to better anti-cancer drugs and antivirals. So we need research to happen in this area. It should be good for the pharmaceutical companies, it should be good for us, but it's not going to happen while companies deny there's a problem. The problem here isn't the chemicals. All chemicals are risky. The problem is the information that goes with these chemicals that should help us to keep things as safe as they can be. The information is increasingly fraudulent. It's not telling us the kind of things that either we or our doctors need to know in order to help us live the lives that we want to live. It's designed to help companies get us to live the life that they want us to live. It's about assays rather than clinical trials. Assays to get the drug on the market and to increase market share, rather than clinical trials to inform clinical practice and keep us as safe as possible. This doesn't just apply to the antidepressants, and it's not just about PSSD. It's a problem that increasingly applies to all drugs that we might take and all of the problems that we might have on these drugs. And it's why your doctor hasn't heard about the problem that you bring to them. The SSRIs in particular, though, don't just cause a problem to the person that you live with who isn't on the pills. They are changing the way the Western world looks. They're but they're affecting everyone that lives in the Western world. Thank you.
Thank you, Professor Healy. That was very interesting. Thank you. Dr. Ajaz, if you want to add anything?
Oh, yes. Thank you, Professor Healy. That was really insightful, and I agree with everything you've mentioned there. It is such a concern. Now, there's just a few points I'd just like to highlight from that around the research, and it's a bit of the elephant in the room. I think certainly we're not here meeting under the premise that antidepressants work, that they cure depression. I think that was one of the early questions that you had. Most drugs, in fact, probably all drugs, work by blocking something. And you don't heal people's brains. You don't heal their lives through blocking stuff. And the idea that we know exactly where these drugs affect the brain and how it happens, I think, is delusional. We don't. We don't know exactly what happens where. We have some idea. Now, if we look at the research around the antidepressants and the effectiveness, straight off the bat, there's a massive publication bias. Now, there's a paper in 2008 that looked at all the registered trials with the FDA in America. If you're going to do a trial on anything, you have to on any drug, you have to register with the FDA, and they compared that to how many of those trials were published. So what they found was that all the trials that are registered with the FDA, about 51% showed something positive for antidepressants. But when they compared that with the amount of those that were published, only the positive ones were published. So 94% of those that were published showed a positive effect. So it's misleading. The research isn't conclusive by any stretch of the imagination. But there's kind of big multi-center trials like the STAR-D from 2006 that have about 4,000 participants, and they show, well, actually, with all said and done, if you're on an antidepressant and you have major depression, there's about 30% remission in about 14 weeks. So they must be doing something. So if we just look at that, we think, okay, fine. We're accepting that at least 2/3 of people won't have any benefit for antidepressants, but we've got a third that have some kind of effect. So if we accept that some people have some clinical benefit from their symptoms on antidepressants, we still can't go to the conclusion that the drugs are designed in a way that's helpful, that they're helping the brain. And I'd like to revert to Irving Kirsch's work, from 25 years ago. In 1998, he looked at the placebo effect of antidepressants, and he showed that 25% of people on antidepressants would have recovered spontaneously if they didn't take the drug. About 50% improved because they believed they were taking something to help their illness. So that power of belief, and that leaves about 25%. And he showed in his work that that is really down to the side effects of the drugs, that told people that actually, am I taking the placebo? Am I taking the control, or am I taking a drug? People were having side effects. I thought, I must be taking the drug, so therefore I must be, I must expect. There's an expectation that happens. So he said that this kind of nocebo effect, 25% accounted for those improvements. So if we look at the people that look at the type of research that's published, if we look at the analysis of the research, there is no argument that holds any scientific weight around these drugs actually being effective. But that's just ignored because it's an inconvenient truth. And that's a really important point that I wanted to make today, that it's not anywhere near a foregone conclusion that these drugs work. Do they help people? Yes, but not for the reasons that we think.
Christoph, I think you had a question or something, a comment?
Well, thank you, Dr. Ajaz. Thank you for pointing out that we're in a disease management system and not in one that's interested in a cure. That is a topic for many medical interventions nowadays. And thank you, Professor Healy, for pointing out the side effect of the PSSD associated with the SSRIs, which are not being discussed. And thank you for pointing out that on this for almost 50 years. I'd like just to throw into the debate the fact that for over 30 years, we know that depression is linked to many, many metabolic factors outside of the brain. We know that it has to do with microbiome dysfunction, with inflammation, with vitamin D deficiency, with thyroid dysfunction, and even nowadays with EMF having an effect on the microbiome. How long can we expect medical education to wait to implement this into the medical curriculum at our medical schools? What do you think?
Okay, well, I don't think things are getting better. I think that things are getting worse. Roughly 3 or 4 years ago, Goldman Sachs put it rather pithily that curing patients is not a good business model. The pharmaceutical industry don't want cures. They want us on as many drugs as they can get us on, treating risk factors as opposed to treating conditions, treating our lipid levels and things like that, rather than treating our heart attacks. So there's that. I'm going to say something else on that point. The Goldman Sachs point was one that came to mind. I've forgotten what the other point was, but oh yes, I know what it was. You mentioned the microbiome and things like that. Well, people routinely, when they get PSSD, think something's gone wrong with their brain, and I try to say to them, no, your brain is probably just fine because there's very little serotonin in your brain or mine. Most of the serotonin in us is in our skin, our bones, our blood, our guts, and that every chance that problems like PSSD are not being caused in the brain at all, they're being caused peripherally in sensory receptors in particular. We've got very brain focused, and that's probably a mistake. But medical education, is it going to change and become less brain focused? Is it going to focus more on cures anytime soon? I don't think so.
Dr. Ajaz, you take a functional health approach and actually specializing in gut-brain health and nutritional psychiatry. So I think that would be a perfect time for you to give your perspective.
Yeah, thank you. Yeah, so what most doctors don't do is ask the question of why. So you can use a diagnostic criteria system, and reliably, to some degree, you can have 10 psychiatrists saying, yes, this is depression. But that's as far as they go. So, well, why does someone have depression? And we just heard, for thyroid, nutritional deficiencies, dysbiosis, altered gut microbiome, neuroinflammation, all these things are contributing by themselves, individually, can cause depression, and often people have multiple problems. But mainstream medicine doesn't ask the why; it's just the what, and then which drug. So the functional health approach is really just asking that question on a fundamental level. And so I try and keep things simple in my clinical approach, because I think there are so many unknowns. So it's safe to assume that most people are nutritionally deficient, because poor mental health is one big sign of that, but also most people don't eat as well as they should, and food is not as nutritious as it was 30 years ago. People don't have as much kind of sunlight, people are indoors more, online more, all those things. So there's a safe assumption that most people that present with mental health problems, present with depression, are nutritionally deficient. And pretty much most people that I don't test everyone because it can be quite expensive. Most people I test are deficient, and I kind of see that in my clinical practice. So one of the things that I work on predominantly is nutrient therapy. So replenishing these levels, and I work by using a particular high dose multivitamin alongside cod liver oil, alongside some probiotics, and try to tailor a brain supplement approach to most people. And what I find is that just that by itself really helps. You give it enough weeks, so you're talking about 2-3 months, but most people before that they start reporting changes in the mood, things are more stable, things are less severe, um, and really it's tremendous, and it's not just kind of case studies that, oh, this is my experience. There's a lot of science behind this, a lot of published data around the impact of nutrient therapy on brain health in general, whether it's depression, whether it's anxiety, ADHD, trauma, PTSD, there's schizophrenia. There's a lot of evidence there. So there's that, and so replenishing nutrition is one thing, but actually what you put into your body is the other thing. So looking after your gut microbiome, and often it's starting off with just cutting out the junk, cutting out the pro-inflammatory foods, the high carb diet, the processed foods, highly processed foods, the bad oils, and so the junk foods, McDonald's and chocolate and all those things. So just really just taking out the rubbish and putting in some nutrients and doing a bit of movement, whether that's exercise or just going out for a walk, and doing things that you enjoy. And that's really important, trying to prioritize yourself. And you kind of have those 3 or 4 things, and you let someone kind of grow into those and to make these positive changes in their life habits. And it really makes a difference. It doesn't have to be more complex like that than that for most people. And that's a general approach I take, and it's really has great results for almost everyone, really.
I just
So,
quickly add
yeah.
into that. Yeah, okay. I use the pills. Well, one of the key things about using pills the way I do are the way they probably should be used is they can be helpful, but you need to remember that while they can be helpful, you also need to know when not to use them. Now, there may be issues about looking at nutrients and things like that, absolutely, but and we've heard that over a 2 or 3 month period that things can improve on this. What people don't hear when they get offered the pills is that the conditions themselves often resolve spontaneously within 2 or 3 months. So you aren't told about this. You're given the impression these are chronic conditions for which you need pills. You're not told about the hazards of the pills. And people say, well, yes, I've been told by my doctor I need these things and they're free of problems. Why not? That's where the problems lie for lots of us.
Mm. So am I right in thinking that you do still prescribe, or you would prescribe certain drugs like an SSRI for, if you feel that it's necessary, because they do help in some cases?
Yes, but
But
just to bring the point
just,
home to you,
yeah.
the SSRI group of drugs can be very good for a condition called OCD, obsessive compulsive disorder. The SSRIs were created by a man called Arvid Carlson, who later went on to run a clinical trial of nicotine in OCD and showed that nicotine was just as good as SSRIs are. Now, SSRIs may suit some people, nicotine may suit others. We often think about what's the best drug. Well, we don't ever know the best drug. We get average effects from clinical trials. The real question is, what's the right drug for me? And it's important that you've got a good relationship with the doctor that you go to in order to be able to work that out, and for him or her to be listening closely to you and be prepared to change things if they don't work out.
And just to add to that, I'm certainly not anti-medication either. I think I'm
Mm.
pro-informed consent. So I lay all the options down for the people that I work with. And it's not about telling them what to do. But I think the difference is that most doctors don't give depressed patients options more than a medication. And so I do prescribe not as many antidepressants as I used to, but certainly for some other conditions in the short term, it can be really helpful. But it's more about informed consent and knowing and being given options where where in other areas that you don't really. So I think there's certainly utility there. Certainly utility, but it's not the start and the end.
So what would be the process, just out of interest, if I came to you as a patient with depressive symptoms, anxiety, etc., would be a first thing to do? Like, would you ask about their diet or their
Yeah, yeah,
lifestyle first of
yes.
all? Or
Yeah.
yeah.
So I take a full
Um,
history, and I always say to people, I need to understand what you're going through. That's the first thing, but I also need to understand the context of that. So I
mhm,
need to know the story of your life,
mhm,
and within that, and if you take time doing that and invest time doing that, you get pretty much everything you need to know about the psychological risk factors, the
mhm,
physiological risk factors, the familial risk factors. Yeah, if they feel comfortable enough to tell their life story, they give you everything you know. So then you're able
mhm,
to compartmentalize. Well, okay, fine. These are the psychological factors of your brain health. Whether it's
mhm,
trauma, whether it's low self-esteem, or what have you, and what are the physiological aspects? Well, you don't eat well. You've had lots of antibiotics. You were born by cesarean section. Um, uh, so you can have a sense of kind of gut health, nutritional imbalances, and those things. Other diagnoses physically that are going on if there's no thyroid and things like that. So the history taking is so important, and you get all the information you need. And it's just about compartmentalizing it, saying, well, this is what we can start with, and this is what we'll kind of work up towards, and really just tailoring it to the individual in
mhm.
that way.
And do you work with health coaches and people who would maybe help people stay on track when it comes to changing their lifestyle and diets?
I,
Or
that that that's
yeah,
a great idea. I generally tend to do that myself.
yeah,
Um,
right,
so
yeah,
yeah,
mhm,
but to work with people, I think it's a challenge to find people that are on the
mhm,
kind of same wavelength, especially as
yes,
a individual kind of a practitioner, um,
mhm,
in that way. But I
of
think
course, yeah,
that's a really good
yeah,
idea. That would
yeah.
Let me
really
May
help
I
me.
quickly
ask a
add to that.
Yes,
question?
Right.
sure.
Okay.
May I ask a question? Because, so many young people I know are on antidepressants or, or for anxiety or depression. And for me, it seems quite clear there are many reasons for young people to be depressed. So, it should be more looking at the root cause than on just, putting young people on antidepressants. And quite a number of them have told me it was just they were prescribed antidepressants over the telephone, a telephone call with a GP, which is quite shocking to me. But so one of these young people said that it took her a year. She was prescribed antidepressants 3 years ago. She wanted to come off them. She really struggled, and it took her a year to wean herself off, and now every now and then she'll take one when she feels she's wobbling. So and others have been. I met a young woman who'd been on for several years, and she's since she was sort of 15 or so. And she still, really just can't seem to get off them, and she would like to get off them. So, what sort of practical advice and steps can people take when they don't feel unwell, but there's this fear associated with coming off them, and obviously some physiological reasons too that makes it so difficult to come off antidepressants?
Who are you asking?
I would like to hear from both of you, actually,
All right.
because I'm sure you probably have different opinions on this.
Oh, I expect so far we've been on much the same page. No, one of the issues I think is that it's a little bit like smoking. If your parents smoked, there's a much better chance that as a child you're going to end up smoking. Increasingly, these days children have parents who are on these drugs, which makes it easier for them to be put on the drugs. And one of the other issues that was raised by Linda about, she asked about coaches and things like this,
Mhm,
lifestyle coaches. Well, increasingly, even psychotherapists refer patients to me, because they're not doing well in the psychotherapy. Wouldn't a pill help soften things up, as it were? Lifestyle coaches do the same kind of thing. Everybody, I mean, the entire culture is geared toward getting you on pills. Even health food shops advertise health foods as a boost to your serotonin system. they're helping sell pills. If the health food doesn't work, but my serotonin system needs a boost, well, I should try a strong booster like a pill. So one of the problems I think we've got a little bit is, and often the way I phrase this may sound a bit awkward, we've replaced holiness, our politics, with health. And a little bit of the problem, or a little bit of the answer has to be getting us out of the health domain. Stop thinking about everything in terms of health. There's a wider world, there's a social world that's going wrong that needs to be sorted out, rather than just put a pill in me to sort me out.
Well, that's really succinctly put, worthy of a quote for sure. And Dr. Ajaz?
Yeah, it's such a hostile world to be growing up in now. It's for young people. I think as older people not growing up in this world, I think it's difficult for us to fully appreciate that. I think education system is a big part of that. I think some of the things that children get taught in school are very harmful and very damaging. I'll give an example quickly about my daughter, and one of the things she's been taught about climate change is that humans are bad, we're destroying the world, and really creating this idea that there's something inherent in human beings, and it's quite pervasive and perversive. There's very little that they get taught about the world that is positive. And this is a burden, I think, that gets put onto children psychologically. I'm just using that as an example, but there's, I think, lots of things around that. So I think it is a lot more hostile than perhaps it has been in the past. So there's these added kind of stressors, and I think our health system's kind of getting worse. And so you put those together, I don't think it's a surprise that we're getting increased rates. And to get people off, what I find my general approach is, well, where can we invest in your brain health? Okay, so how can you invest first before you take something away? Because your brain's developed some dependency around it, so it's going to struggle when you take it away. I think it's safe to assume that, although there is a variation, some people come off them really easily, and other people really struggle. By even a small decrease, they really struggle. Lots of headaches, nausea. They just can't cope. So there is a big variation. I don't understand why there's such a variation. Well, some people respond better than others, but those who are struggling, I see how can you invest in your brain health, and nutrients is one of those ways. Exercise, psychotherapy. How can you enhance all aspects of your brain health, and then try again? And that's my general approach that I find kind of works. If you're taking something away that is doing something, you need to replace it. You need to enhance it and then take it away, rather than just taking something away and then expecting someone to be okay.
But for most people, and what would be a realistic time? If they've been on a drug and they're feeling okay and they're ready to step away from it, does it need to take months, or is it something that they can wean off in 2 weeks?
Oh, one of the thing is we're different, and there are people, as you've just heard, who can get off these drugs without too much problem. There are people who can get off them by tapering and weaning slowly. And then there's people who can't get off at all. And this is probably a fairly large group. And PSSD is probably part of this group. I mean, it's a thing that shows up in particular when you try to come off the drug. You may not be aware you have the problem until you try to get off the drug. And then the condition you have, the gentle numbness, the lack of being able to make love, the lack of interest to make love, gets profoundly worse. So it's part of the withdrawal spectrum, and we know that this can last for decades.
That was one of my questions, actually, because I was wondering if this kind of like PSSD, if there's something that occurs after someone came off the drugs, or if it's already something that happened during their time on the drug and it just doesn't get any better. But you just said that it can actually be an effect of withdrawal, like a
Yes,
withdrawal effect. Yeah.
sure. It becomes
Okay.
more obvious then, but it's
Mm.
clear that there's a bunch of people who have it while they're on the drug. It's just we
Mhm.
can't say for sure this is what it is because you have to come off the drug for us to, I mean, for us to get the post bit. But if you take into account there's roughly whatever number, 15% of the population in the UK who are hooked on these drugs and can't get off them all that easily. If they do come off them, lots of them expect they'll be able to get back and make love the way they used to be able to do. It's probably for sure that a large proportion of people won't be able to do so. So we know that roughly 1% of people who've been on these drugs, maybe as high as 4 or 5%, will get PSSD. But in actual fact, if people could get off the drugs one way or the other, we might find that a lot more of the UK population have PSSD than we thought.
Mhm.
Our colleague Christoph
Yeah.
Plothe is wanting to come and ask a question, and I have another question, and there's a question in the newsroom. But I wanted to ask actually about psilocybin, because I read a study about 3 years ago from, I think it was a study, it could have been University College London, it was definitely a UK study, where they took a group of 20 very people who were with intractable depression, who tried many times to come off their antidepressants, and it was very experimental, and they gave them, I think it was 2 doses of a chemical psilocybin, sort of a drug company manufactured psilocybin, I understand. The one dose was a sort of a test dose, and the second dose was a week later, and it was a more substantial dose. And a number of these people managed to come off the antidepressants, and they've sort of measured it sort of 3 months later, and it seemed to be sustained. So I wondered, are you aware of any further research in that area? Because wouldn't that be amazing if there was a really alternative and method of coming off?
There's a big problem here. First of all, it isn't a way to get off. It can be a way to treat people. Intractable depression didn't exist before the SSRIs. Okay, so they're part of the problem as opposed to anything else. But the big problem we have is that the pharmaceutical companies will not want you to be cured, in essence, with 1 or 2 treatments. That's not a good business model.
Yeah, and just to add, from my perspective, I'm not expert on psilocybin, but we're talking about something different here. We're talking about something that's a natural kind of herbal that has been used for centuries in different civilizations, and there's something in that that some things last the test of time. And if we look, there's clear evidence that it's been used across kind of millennia. Yeah, I think there's a lot in there, but I think navigating that with the external pressures, the decisions aren't made for patient best interests, and it's the other vested interests that allow things to come to the fore or not. So it'd be interesting to see how that plays out, irrespective of the data, which I expect to be stronger and stronger as time goes by.
Thank you.
Yeah, well, thank you again to the 2 speakers for hosting such an important discussion here, because it's such an important topic of our times, and thank you for highlighting the position of the industry itself. The 2 strategies that the industry has been using in the last few years was increasing ads, even including TV. It's not legal in all countries yet, but even here in Germany, you see more and more since the last 3 years for some strange reason. And also the second strategy was to include more and more psychiatric diagnosis in the Diagnostic and Statistical Manual of Mental Disorders in DSM-5. So we now have disruptive mood dysregulation disorder, hoarding disorder, restrictive food intake disorder, gaming disorder, and for all of them, of course, you have the right medication in place. And these are two quite obvious strategies. Is anybody in the profession actually opposing these methods? Are there any voices that can be heard apart from your two critical voices here tonight?
Less and less. The problem, I think, people who think the way we do here this evening have is we talk to each other and we think things are getting better because we're talking to people who have the same kinds of views as we have. It's a bit of an echo chamber. But if you ask me, are things getting better? No, they're not. And it goes back to what Tess said. She sees an increasing number of teenagers who are on all these pills. And that is the case. You know, you've got teens saying, you know, eat vegan, go to the gym, and take your SSRI. That's the mentality. And things are getting worse, not better.
We have a question from the newsroom. What levels of vitamin D do guests think would help mental health issues? Maybe Dr. Ajaz?
Yeah. Well, I think but there's certain nutrients that you would like to be in the top quintile. So really towards the top end of the normal range. So depending on how you kind of measure it, I think it's different in different kind of countries, but you're really looking at that kind of top quintile. There is a problem with the daily recommended values of nutrients that we see in every kind of label. They're traditionally based upon how much you need in order not to be sick, with a specific nutrient kind of illness, nutrient-based illness. And that's very different to maintaining health. They're alone trying to optimize your brain health. So there's certain nutrients that we certainly want in that top quintile.
Okay, and so that's vitamin D. Can you say which other vitamins?
Yeah, so if we look at when it comes to nutrients, you have to be careful because they often work in pairs and in families. So you know, if you say take a lot of zinc, that can reduce the copper, and then that could low zinc or low copper can cause can increase the risk of depression. So you just have to be very careful. So that's why I prefer to use a multivitamin that allows more kind of equilibrium around the nutrient level, so they can kind of increase the ones that need increasing can increase without the others decreasing. But we're looking at zinc, selenium, magnesium, copper. You know, there's some of the common nutrients, vitamin D, as we've mentioned, that are associated with increased risk of depression, for sure.
Well, I mean, my thought now is, again, what does someone do? Just in practical terms, if we have someone who's feeling low and down and anxious, what's the way forward? I mean, where to go as a patient or as a person with these issues? If not to the GP, because that's where they're probably going to get an antidepressant prescribed. So what's the best way?
I mean, if we look at the national guidelines, people with moderate depression or mild to moderate depression are still advised to exercise and to do some type of therapy. So are you talking to someone about your problems? And I think that's always a good starting point. I think exercise is probably the best antidepressant out there, but you know, there's a whole range of alternative therapies that are just as strong in terms of the data when it comes to antidepressants, if we look at it from that perspective. So acupuncture is very helpful, for example. Talk about exercise, whether that's walking or whether that's resistance training in particular. You know, taking out the junk food, because they have a negative effect on your brain. Taking out the alcohol in the short term, there might be some problems, but we know alcohol and drugs are kind of depressants in that way. So really looking at your lifestyle, how you live your life, and being honest about that. And that can be a struggle when you're depressed. So if you want to start off by just walking every day, you know, for 30 minutes, every day and build up on that. And it's your mindset. Just knowing what you need to do to change is the first step, and then committing to trying to do that, and not doing it by yourself. You know, it's trying to, you can get kind of support, whether it's through your partner or whether a friend or a family member. So there's that kind of accountability and support as well. And I think, you know, nutrients are, you know, you don't need a prescription for that. So, you know, nutrients, cod liver oil, multivitamin, and you know, I think they would be starting points, and that's certainly where I start with many of my patients. And I always kind of emphasize that just do something that you enjoy, and that's really important, because most people have forgotten what it feels like, and to be able to put themselves first in that way. That's where I would start with.
Can I chip in here and give a slightly different kind of answer? Not the opposite, but just picking up a different set of issues, which is at the politics of the whole thing. In 1962, we had a thalidomide crisis, which led to a change in the regulation of drugs. Before that, drugs like food and automobiles and the stock market, the key point behind regulation was to keep us safe. In 1962, the regulations changed and companies were told to show that their drugs worked. Now, after 1962, for 20 years or so, pregnant women didn't take a drug at all during pregnancy. Now they've gone even further. They don't take soft cheeses, they don't take processed meats, they don't take alcohol, etc., but they're increasingly taking drugs for one reason, which is drugs, unlike food and exercise and anything else, come with a label stuck to them saying, this works. That's a problem, and that's what's driving a lot of the behavior. One of the other things is not what do we need to do. Doctors need to wake up, because if the drugs work so well and are free of problems, doctors are going out of business. They're going to be replaced by cheaper prescribers, nurses, pharmacists, and pretty soon robots. It's in the interests of doctors to let you know that these drugs may be useful, but actually they're poisons, and the art of medicine is all about bringing good out of the useful poison. And for that to happen, you need to have a good relationship. The doctor needs to have a good relationship with you, or else you're going to end up injured and he's going to be out of business, or she.
Interesting. And on that note, let's we're going to have to move on. We could have asked 100 more questions, and I certainly hope to chat more with you about some of the things that we've discussed, the luxury of being on this side of the screen. But thank you so much, both of you, Dr. Healy, Professor Healy, and Dr. Ajaz. And I do hope you'll return when we have another session on mind and mental health. Thank you very much. And thank you, Linda, for hosting that lovely discussion.